Hello. Today I will be discussing some of the latest developments in the prediction and prevention of preeclampsia. Of course, you all know that preeclampsia is a major cause of maternal and perinatal mortality and morbidity. It is estimated that more than 50,000 women die every year throughout the world as a result of preeclampsia. And preeclampsia, of course, has long-term consequences for the mother, with a doubling in her risk of major cardiovascular disease. Similarly, for the baby, there is a very high risk of perinatal death, cerebral palsy, primarily as a result of the associated fetal growth restriction and premature birth. And it is also believed that babies that do survive in adulthood, they are at increased risk of cardiovascular disease. First, let's discuss developments in the prediction of preeclampsia. Let us look at what is the established method of screening for preeclampsia. And here I summarize the major international bodies that have made recommendations on how to screen for preeclampsia. In all of the existing methods, the basis of screening is obtaining a series of factors from the maternal history. In England, for example, with the NICE guidelines, we have 5 major risk factors, and if you have any one of those, previous pregnancy affected by preeclampsia, chronic hypertension, chronic renal disease, maternal diabetes, autoimmune disease with SLE and antiphospholipid syndrome, then you're classified as being screen positive. You're also classified as being screen positive if you have any 2 of 5 moderate risk factors that relate to maternal age and size and the family history of preeclampsia where you're in your first or previous pregnancies. In the United States, the American College of Obstetricians and Gynecologists recommends that women at high risk of developing preeclampsia should receive aspirin, but they classify somebody as being at high risk if they have had 2 previous pregnancies affected by preeclampsia or 1 affected by preeclampsia leading to delivery before 34 weeks. Until now, we are not certain about the performance of these methods of screening. We do not really know what is the detection rate and the screen positive rate. The Fetal Medicine Foundation over the last decade has developed a different approach to screening. We use Bayes' theorem to estimate the prior risk, which is derived from a multiple regression model of the various maternal risk factors, where each one of the factors is given its own separate importance, and such an approach takes into consideration the interrelationship between the different factors. Then the prior risk is modified by the results of various biophysical and biochemical examinations. We measure various biomarkers. We modify the values to convert them into multiples of the normal median, and then we multiply the prior risk with the likelihood ratios derived from these biomarkers to estimate the posterior risk. And with this method, we can estimate the risk of any individual of developing preeclampsia before any desired gestation. So if we want to derive the risk of severe early onset preeclampsia before 32 weeks, we can do so, or preterm preeclampsia with delivery before 37 weeks, or term preeclampsia with delivery at or after 37 weeks. Over the years, we have examined a very large number of potential biomarkers, but essentially 4 have been found to be useful in screening in the first trimester at around 11 to 13 weeks. And these are the measurement of the mean arterial pressure, the Doppler measurement of the uterine artery pulsability index, and the biochemical markers of PAB-A, pregnancy-associated plasma protein A, and PLGF, placental growth factor. And in a major publication involving more than 35,000 pregnancies that were prospectively examined using these biomarkers, we found that at a false positive rate of 10%, the detection rate of preeclampsia before 34 weeks was 90%, preterm preeclampsia before 37 weeks was 75%, and term preeclampsia was about 45%. And this, of course, was the first step. Once you establish a method of screening, you need to validate your results in a new set of patients. In this slide, you can see the results of the first validation study. This involved more than 8,000 prospectively examined singleton pregnancies in a study that was part of the aspirin trial, and it involved patients that were examined in Spain, in Italy, in Belgium, in Greece, and several centers in the United Kingdom. And this study showed that the prediction was correct. We had very, very similar results in the validation model, so we can conclude that it is true that with the first trimester combined test, we can detect about 90% of cases of preeclampsia before 34 weeks, 75% of preeclampsia before 37 weeks, and about 45% of preeclampsia at term. The second validation study came from a multi-center study that was funded by the British government. We prospectively examined in 7 National Health System hospitals more than 16,000 women at 11 to 13 weeks. And in these women, the clinicians decided whether to recommend aspirin or not based on the NICE guidelines. We performed the combined test, but we did not give the results to the patients or to their managing clinicians. This study, for the first time now, demonstrated what is the performance of screening by the NICE guidelines. At a screen positive rate of about 10%, NICE guidelines could identify about 40% of women with preterm preeclampsia, 26% of women with term preeclampsia, and the overall rate of detection of all preeclampsia was about 30%. So we now know that the current method of screening performs quite poorly. The SPRE study, as it is known, also demonstrated that with the first trimester combined test, using history, mean arterial pressure, placental growth factor, and uterine artery pulsability index, the performance of screening, the detection rate for the same screen positive rate of about 10% was twice as good with our approach compared to that using the NICE guidelines. Here you can see the ROC curves for the performance of each individual marker or combinations of different markers. And the best combination was that of the mean arterial pressure, uterine artery pulsatility index, and placental growth factor. In this slide, I summarize all of our extensive studies of first trimester screening in singleton pregnancies at 11 to 13 weeks, involving more than 60,000 pregnancies. And you can see the performance of screening for different combinations of the various biomarkers and an overall detection rate of more than 75% of preterm preeclampsia by the triple test. We now have a good method of screening. Of course, we need to go further. We need to carry out more research. We need to find new biomarkers. In the case of screening for Downs, we had started with a detection rate of 30% using maternal age. We advanced to 60 to 70% using second trimester serum biochemistry. We went further to about 90% using the first trimester combined test. And of course, now we have gone to more than 99% using cell-free DNA testing. So in terms of screening for preeclampsia, we have gone from about 40% using NICE guidelines to more than 75% using the first trimester combined test. Still a long way to go, but a great major advancement over what we used to have. In this section, I will address the question of which risk cutoff we should be using in the prediction of preterm preeclampsia. Before I address the question of selecting the appropriate risk cutoff in screening for preterm preeclampsia, I want us to be reminded of the lessons that you have learned from screening for Down syndrome. We all know that with the first trimester combined test, the detection rate is about 90% for a screen positive or false positive rate of about 5%. However, in England, the recommended risk cutoff to classify somebody as being at high risk is 1 in 150 at term, which is equivalent to a risk of 1 in 100 at 12 weeks. With this risk cutoff, the performance of screening is not a detection of 90 for 5, but it is a detection of about 86 to 88% for a screen positive rate of about 2.5 to 3%. And when we are counseling an individual patient, we cannot give this summary statistic for the whole population because the performance of screening is dependent, very much so, on the prior risk. And in the context of Downs, the prior risk is defined by the maternal age-related risk. And you can see from the graph on your right that for a woman at the age of 20, the detection rate is less than 80%, and of course, the screen positive rate is about 1%. Whereas for a woman at the age of 40 or 50, the detection rate is more than 95%, but then the screen positive rate is more than 30%. So in screening and in counseling the individual patient, we cannot give the overall performance, but the detection and screen positive rate will vary with the prior risk. Well, we have exactly the same situation in screening for preeclampsia. We have already learned that in screening for preeclampsia, there is a series of maternal factors that defines the prior risk. The risk is higher in black women than in white women. It is higher in women that are of advanced maternal age. It is higher in women that have a high body mass index. It is higher in women that have got a family history of preeclampsia. So if we are going to fix the risk cutoff in population screening, the performance will vary in different populations, because in different populations we'll have different prior risks. These are the results from prospective screening in these more than 60,000 pregnancies. And you can see that we can either use a risk cutoff of 1 in 70 for our population with our racial mix-up to have a screen positive rate of about 10%. However, you can see that in white women there is a lower overall risk of developing preeclampsia, and the screen positive rate of 10% is achieved with a risk cutoff of 1 in 100. But if we were to use a risk cutoff of 1 in 100 in a predominantly black population, the screen positive rate would be much higher than 10%, but of course at the same time we will have a much better detection rate. And in Southeast Asians, the situation is also similar to that in black women. There is a higher risk of preeclampsia, and for a risk cutoff of 1 in 100, the screen positive rate is going to be more than about 15%. So if you want to adhere to the screen positive rate of around 10%, we should be selecting a risk cutoff of 1 in 70. So let me re-emphasize this point. When we are screening in a multi-ethnic society, we cannot possibly use different risk cutoff for different racial groups. In screening for Downs, we cannot use a different risk cutoff for screening women that are in their 20s and a different one for women in their 30s and a different one for women in their 40s. In terms of the public health perspective, you select one risk cutoff and then you accept the reality that the screen positive and detection rate will vary depending on your prior risk. My personal view is that we should be using overall a risk cutoff of 1 in 100. If black women are at higher risk of developing preeclampsia, then there will be a higher screen positive rate. But we should tolerate that because we will be achieving a much better detection rate. And one of the differences in terms of screening for Downs, for example, by comparison with screening for preeclampsia, in the case of Downs, at least until recently, the consequence of being classified as being screen positive was to go through an invasive test that carries a risk of miscarriage, whereas in the case of somebody being classified as being screen positive for preeclampsia, they would be treated with aspirin that does not have any known adverse effects on the mother or the baby. I will now present some of the important recent findings in relation to prevention of preeclampsia. I will start off by summarizing our knowledge acquired over the last 50 years. We know that bed rest and various dietary manipulations do not reduce the risk of preeclampsia. The only thing that we know is beneficial is in populations or individual women with low intake of calcium. Calcium supplementation can halve the risk of preeclampsia. Bed rest, salt restriction, various vitamins are not useful. I now come to the long history of aspirin. In 1985, a study from Paris, reported in The Lancet, examined 102 women that were at very high risk of developing preeclampsia. And in that study, women were given 150 milligrams of aspirin per day, starting from 12 weeks. In the subgroup of women that received aspirin, there were no cases of preeclampsia, fetal growth restriction, stillbirth. Whereas in the subgroup that did not receive aspirin, quite a few women developed preeclampsia or had growth restriction and stillbirth. So that was the beginning. Let us now see what happened in the subsequent decades. A series of major multicenter studies were conducted in which, surprisingly, the dose of aspirin varied from 40 to 160 milligrams, and in the vast majority of the studies, the dose of aspirin was less than 100 milligrams. In most of the studies, the starting point of giving aspirin was at any time between 12 and 32 weeks. In the majority of the studies, it was beyond 16 weeks. There were many different strategies of selecting the high-risk group, and there were at least 14 different definitions of preeclampsia. Somehow, these greatly varied studies in terms of their dose of aspirin, starting point, design, and endpoint were put together through a meta-analysis that concluded that the use of aspirin in high-risk women has only a mild or moderate effect in reducing the risk of preeclampsia by about 10%. I feel very strongly and very critical of the rationale of some meta-analyses where completely heterogeneous types of studies are somehow put together and conclusions are reached that, if wrong, dominate thought for several decades. And that is unfortunately what has happened in the case of these meta-analyses in relation to the various studies that have been conducted until that time. So if you ask any clinician in any part of the world, most probably they will tell you that aspirin is useful at a dose depending on what you can buy from the local chemist or the local petrol station in any given country, ranging from 40 to 60 to 80, usually milligrams, given at any time in pregnancy, reduces the risk of preeclampsia by 10%. Is this true? To address this question, we decided to conduct, hopefully, the definitive study in relation to the use of aspirin. A series of centers from Europe participated in this multi-center study, which was funded by the European Union. We decided that the dose of aspirin should be 150 milligrams per day, because after all, this is what was the original recommended dose. And over the years, we have also learned that lower doses of aspirin will find high proportions of the population that are not responders. So if you want to maximize the benefit for the potential value of aspirin, we have to use the dose of 150 milligrams. We decided that it was important to start treatment before 16 weeks and preferably at around 12 weeks. What was the reason for that? Well, if aspirin works by improving placentation, placentation is completed by 16 weeks, and therefore, if we want to affect placentation, we should be treating at the time when placentation is still ongoing. We wanted to stop at 36 weeks because we had a concern that perhaps aspirin could produce brain hemorrhage or other hemorrhagic events for the fetus and the neonate. So we wanted to stop at 36 weeks before the vast majority of women would be delivering. And then we had a decision to make as to what was the best time to give the aspirin in general. This is being given in the morning or at lunchtime, but there are a series of studies, mainly from Spain, that have addressed the question through randomized studies as to which is the best time, in the morning, at lunchtime, or in the evening, in giving aspirin, and they concluded that the greatest effectiveness in prevention of preeclampsia was achieved if the drug was given in the evening. And then we had to address the question of what is the outcome. Any preeclampsia, term preeclampsia, or preterm preeclampsia. Accumulated evidence over the last few decades suggests that more or less we can divide preeclampsia into preterm and term, and maybe the pathophysiology of the two conditions, although they may be overlapping, is likely to be different, with preterm preeclampsia being predominantly a consequence of impaired placentation, and term preeclampsia being a consequence of metabolic disorders in the mother, pre-existing cardiovascular risk factors, and in many respects not truly understanding term preeclampsia. So we wanted to limit our outcome measure to preterm preeclampsia. And the last point was, how do you go about selecting the high-risk group that you need to find out if they can benefit from the use of aspirin? Well, it was obvious on the basis of all of our studies over the last decade that the best way of selecting the high-risk group, where we would maximize the detection rate, was by using the FMF algorithm with a combination of maternal factors with biomarkers. We assumed that aspirin at 150 milligrams per day would reduce the rate of preeclampsia, preterm preeclampsia, by 50%. We were also assuming that about half of the screen-positive women would agree to take part in the study. On the basis of these assumptions and the results of our screening studies, we arrived at the conclusion that we needed to randomize 1,600 high-risk women to achieve significance with a power of 90%. We were very proud with the rate of recruitment to the study, which was essentially completed within 10 months. So I am very happy about these results, and it demonstrates the commitment of the various centers towards at least addressing the question whether aspirin is useful or not. And now the results. We have screened more than 25,000 women. We identified a high-risk group of about 11%. We had a series of exclusion criteria. We then had a good uptake of randomization. Some of the women that enthusiastically accepted randomization to begin with subsequently decided to withdraw. And we had our final target for further assessment. And the study was published in the New England Journal of Medicine. And the results. Aspirin at 150 milligrams per day, starting from 11 to 14 and up to 36 weeks, had a major reduction in the rate of preterm preeclampsia of more than 60%, a reduction in the rate of preeclampsia before 34 weeks of more than 80%, and the reduction of early preeclampsia before 32 weeks of nearly 90%. But, perhaps as expected, it had no significant effect on the incidence of term preeclampsia. So here we are. A discussion that has lasted for more than 25 years, and a process that, in my mind, has deprived women of the major benefit of aspirin because of the way we conducted our studies in the past, has now reached a new starting point. Aspirin at 150 milligrams per day from 12 to 36 weeks, preferably given at night, nearly eliminates the most extreme forms, the most severe forms of preeclampsia at less than 32 weeks, and it reduces the rate of preterm preeclampsia by more than 60%. Not 10, not aspirin of 40 or 50 or 60 or 75 or 81 milligrams, purely because that is the dose of the drug sold in the local petrol station. But the scientific basis of treatment should not be defined by the attendant of a petrol station. The right dose of aspirin is 150 milligrams. The starting point is 12 weeks. The finishing point is 36 weeks. Major impact in reducing one of the major causes of death and handicap in obstetrics. In a secondary analysis of the ASPER trial, we asked the very simple question whether compliance matters. Well, one thing is certain in medicine. A drug never works if the patient does not take it. And it was very likely that the better the compliance, the more effective the drug would be. We took a cutoff of a compliance of 90%, which was met by the vast majority of the women in the ASPER trial. And here now, the effectiveness of aspirin was greater in terms of reducing the rate of preterm preeclampsia. The next question that we addressed through another secondary analysis of the ASPER data was whether it matters which risk group you come from. Does it matter whether you are young or older? Does it matter whether you are thin or overweight? Does it matter whether you are black or white? Does it matter whether you smoke or not? Does it matter whether you have a family history of preeclampsia, whether you are an alip, or whether you had preeclampsia in a previous pregnancy or not? And you can see that you have a variation in the values from each one of the subgroups, but all of the results suggest that none of these factors have any major effect or a deviation from the overall result. And I can conclude from this that, for example, a question that I'm often asked, should you be giving the same dose of aspirin to a woman that is thin as to a woman that is overweight? The answer is yes, we can. With a dose of 150 milligrams, it doesn't seem to matter whether you are thin or overweight. It doesn't matter which group you come from. There was only one factor in the maternal history that appeared not to be affected by the use of aspirin, and that was the women with chronic hypertension. And this is interesting because chronic hypertension, of course, is the most important risk factor for the development of preeclampsia. If you start off your pregnancy with chronic hypertension, you have a 20% risk that you will develop preeclampsia. But somehow aspirin was not effective in this group. We are currently investigating alternative strategies for this group of women, including very strict control of their blood pressure starting from the first trimester and the possible value of pravastatin in the prevention of preeclampsia in this group. But it appears that all other risk factors do not deviate in their responsiveness to aspirin except chronic hypertension. We took the story further and we asked the question, if we look at the group of women that did not have chronic hypertension and the subgroup that actually had a good compliance of more than 90%, well, in those women that still constitute the majority of the population, the reduction in the rate of preterm preeclampsia may be up to 95%. At this point, I would also like to address a question that is often asked as to why not give aspirin to everybody and why go through this laborious process of screening. Well, there are two reasons for that. The first one is that I believe that we will get a much better compliance if we identify somebody as being at high risk and we explain to them that it would be beneficial for them to take aspirin. And the second reason, of course, is that although so far we believe that aspirin is safe, this cannot be always stated if you have mass treatment of the whole population. There is some evidence from the use of aspirin in older people as part of prevention of cardiovascular disease that aspirin increases the risk of hemorrhagic events a little bit. But if you're treating a lot of people, then that small possible increase in hemorrhagic events would have a major adverse effect. So I think it is rational that we should screen, identify the high-risk group, where for sure aspirin would be beneficial, and emphasize to these women the necessity of a high compliance. A question that is often asked is, if a woman is at high risk of preeclampsia because she has chronic hypertension or diabetes, or she had preeclampsia in a previous pregnancy, should we not just be treating these women and do screening in the low-risk group. In many respects, this set of questions were asked many years ago when we introduced screening in the first trimester for Down syndrome. People at that time were saying, I think we should continue to offer invasive testing to women over the age of 35 and offer screening to women under the age of 35. Of course, all of that argument very soon became a non-argument, and the reason mainly why that happened is because women in the older age groups understood better than doctors and public health doctors that they did not want to have invasive testing if their combined test risk was reducing their maternal age-related risk. So here you have a woman who is 40 years old. By the traditional 1970s approach to screening, she should be offered invasive testing. By the 90s method of combined screening, the nucal is good, Fribida is good, Pabe is good. Her risk becomes the same as when she was 20 years old. Should we still be giving her an invasive test just because she's 40 years old? Well, of course not. Should we therefore not adopt the same ideology, the same philosophy when we move into the new era of screening for preeclampsia? Should we be treating women because by the traditional approach are at high risk? Or should we be screening also those women, not only because many of them will now be shown to be at low risk, so that at an early stage in pregnancy, we can reassure them that despite the fact that they had a previous pregnancy with preeclampsia or other risk factors, actually their risk is very low. So reassure them, make them feel good about it by telling them that their risk is low. And the other way around, if such women are found to be at a particularly high risk, then monitor them even more closely. Well, to address this question, we did this secondary analysis again of the aspirin trial results, and the answer is very, very simple. In women with at least one high risk factor from the NICE guidelines, or at least two moderate risk factors, if they're screened positive by the FMF algorithm, they have a major increase in risk of developing preterm preeclampsia. But the other way around, a woman that is at high risk because they are NICE criteria positive, but through the FMF algorithm, they are found to be at low risk, actually, these women have a lower than the background risk of developing preeclampsia. I hope that this data will settle this question and it will not linger on and on for too long. So, a woman that had previous affected pregnancies with preeclampsia is at high risk of developing preeclampsia in this pregnancy. If we screen this woman with the FMF algorithm and she's found to be at high risk, then she should be monitored very, very closely. She should receive aspirin, and we have to be monitoring her closely for the development of severe early preeclampsia. If, on the other hand, the same woman is screened negative by the FMF algorithm, she can be reassured from 12 weeks that she is unlikely to develop preeclampsia. We now summarize the evidence in relation to the dose, the timing of onset of aspirin, and the target of aspirin therapy. In this recently published meta-analysis involving 16 trials, we have found that aspirin does not have any effect on the rate of term preeclampsia, but it has a major effect in reducing the rate of preterm preeclampsia. In the same meta-analysis, in relation to prevention of preterm preeclampsia, we found that aspirin at less than 100 milligrams started after 16 weeks, it does not reduce the rate of preterm preeclampsia. Whereas aspirin, at the minimum dose of 100 milligrams and starting before 16 weeks, reduces the rate of preterm preeclampsia by 67%. Many doctors are worried that aspirin at 150 milligrams per day may increase the risk of placental abruption and antepartum hemorrhage. And this is a justified concern, because most of the studies of the past had shown that aspirin does not increase the risk of abruption, but in most of those studies, the dose of aspirin was less than 100 milligrams. To address this question, we conducted a major meta-analysis of all of the published studies that gave information on the dose and the timing of aspirin, and they reported on the rate of abruption or antepartum hemorrhage. And we were reassured to find that aspirin at less than 100 milligrams per day, given either before or after 16 weeks, does not increase the rate of abruption. But unfortunately, of course, we have already shown that such a low dose does not improve the risk of preeclampsia either. If we look at the dose of aspirin of more than 100 milligrams now, we found a very interesting finding, that if you start before 16 weeks, you are tending to reduce the risk of abruption, whereas if you start after 16 weeks, you are increasing the risk of abruption. And there was a significant difference between the effects of more than 100 milligrams given before compared to after 16 weeks. To me, this is completely logical. One of the major causes of abruption is impaired placentation. And if aspirin is given at the right dose and at the right time, it makes sense that by improving placentation, it would reduce the rate of abruption. Whereas if you give a high dose of aspirin to women beyond 16 weeks, in the presence of impaired placentation, which you cannot improve anymore, you may well be increasing the risk of hemorrhage, including placental abruption. So the lesson from this is aspirin before 16 weeks at more than 100 milligrams, not only it does not increase, but it may well decrease the risk of abruption. I now want to address a question relating to cost effectiveness. Everybody is worried about the cost and whether it would be beneficial, this treatment, to justify the cost of offering screening to the whole population. In the primary analysis of the ASPRE trial, we found that the rate of admission to the neonatal intensive care unit was not significantly different between those that had received aspirin compared to those that had received placebo. And this was a bit worrying because people were saying, well, you may well be reducing the risk of preterm preeclampsia, but you're not demonstrating any benefit for the babies. So we looked at the data again in greater detail in this secondary analysis. And we confirmed that although the overall rate of admission to the neonatal intensive care unit was not different between the two groups, the rate of admission for babies that were born before 32 weeks was significantly lower in the aspirin group. And this is important. It is important because more than 80% of the total length of stay arises from babies that are born before 32 weeks. Indeed, more than 80% of the total length of stay for more than 14 days arises from the very premature group. You know, quite often you take a high-risk pregnancy, baby is born, and you may admit it into the neonatal intensive care unit for a few hours or a day, and then they're released. What really matters, a marker of morbidity, and perhaps long-term morbidity, is how long you actually stay in the neonatal intensive care unit. And we found this massively significant reduction in the overall length of stay in the neonatal intensive care by 68%. So aspirin had a major reduction in the total length of stay in the neonatal intensive care unit. And this has important implications. What does this 68% reduction in the total length of stay mean in terms of costs? If we screen 10,000 women and we identify 10% as being at high risk for preterm preeclampsia, and then we treat this group with aspirin, we estimated that by comparison to a group that does not receive aspirin, we are reducing the mean length of stay in the neonatal intensive care unit by 1.4 days. If we then take 1,000 pregnancies, each contributing 1.4 days, we have a total saving of 1,400 days of neonatal intensive care in the group that would receive treatment with aspirin. And if I take an average cost of $2,000 per day in the neonatal intensive care unit, then we have a cost saving of several $million. And we can then use this to offer screening to the total population of the 10,000 pregnancies. To be cost neutral, we have $280 per screening test. And it is absolutely clear that the cost of each screening test is much, much less than $280. Why? Well, what are the components of screening? Firstly, taking a history. Well, this is part of routine antenatal care. Secondly, measuring of the mean arterial pressure. Well, if the mean arterial pressure is to be measured properly, it takes about 5 minutes, and proper care has to be taken in allowing the women to rest, selecting the right cuff, measuring the blood pressure in both the left and the right arm once, and then waiting for a minute and measuring it again. But I think that in most healthcare systems, an auxiliary nurse can easily be trained to undertake this task, And I don't believe that this would be very expensive at all. Measurement of the uterine artery pulsatility index. Well, in countries where there is routine first trimester screening, either by just performing an ultrasound scan at 11 to 13 weeks, or by performing the combined test in screening for Downs, the patient is there, the ultrasound machines are exactly the same, they all now have facilities for color Doppler. It will add to the first trimester ultrasound scan a couple of minutes to measure the uterine artery pulsatility index. What about the measurement of placental growth factor? Well, again, we have an infrastructure of screening for Down syndrome. The equipment are available. A blood sample is collected from the women. Free beta hCG and PABA are measured. The cost of measuring the placental growth factor would be marginal. And altogether, we come nowhere near the amount of cost saving from the major reduction in the length of stay in the neonatal intensive care unit. But this is not all. A major reduction in the total length of stay that is primarily attributed to a reduction in the rate of very premature birth as a consequence of reduction in the rate of early preeclampsia, more than 80% of preeclampsia before 34 weeks, 90% reduction in the rate of preeclampsia before 32 weeks, translates into a major decrease in risk of being born prematurely. And what is the consequence of that? We have the results of an extremely good study from France, published this year in the British Medical Journal, that shows the massive difference in terms of death and handicap in survivors within 2 years of premature birth. You can see a massive difference as to whether you're born before or after 32 weeks. A tenfold difference between the two. But you have more than that. A few years ago, there was a major epidemiological study from Norway published in the New England Journal of Medicine that looked at babies according to the gestational age at delivery, in what happened to them in terms of the risk of death in the first 5 years of life, the risk of cerebral palsy, but also the chances of impairment that will be interfering with their ability to integrate into the society and take up a job in the subsequent 20 years and beyond. And you can see that there is a massive difference in terms of risk of death within 5 years, cerebral palsy, and inability or impairment in working in the long term if you are born before 30, before 32, before 34 weeks. And although the individual statistics may have changed because of improved neonatal care in the last few decades, still the relative proportion of risks for each one of those components remains substantial. So a reduction in the risk of severe early preeclampsia translated into a reduction in risk of premature birth, translated into a major reduction in length of stay and therefore cost, immediate cost to the healthcare system, is also translated into a reduction in death, handicap, and long-term cost from looking after such individuals. So what is new? What have we learned in the last year, and what have we added to the knowledge of the last 30 years? We have learned that aspirin at more than 100 milligrams per day, starting at less than 16 weeks, can reduce the risk of preeclampsia before 32 weeks by 90%, preeclampsia before 34 weeks by 80%, preeclampsia before 37 weeks by 65%, and higher if you have a good compliance. We have an associated reduction in the risk of abruption by 30% and a reduction in the length of stay in neonatal intensive care by 65%. We have learned that it is important in modern prenatal care to adopt a new philosophy. Our approach must be to identify women at high risk of important pregnancy complications, and preeclampsia is certainly one of the most important pregnancy complications. Identify women in the beginning of the pregnancy and do so effectively and treat them appropriately to prevent pregnancy complications. I think the time has come for us to implement this new approach to prenatal care for the benefit of the mothers and their babies and the society. Thank you.